session is being recorded, and the recording link will be uploaded to SharePoint along with the slides from the session and the notes for your use. That way, anyone that missed the presentation or that wants to go back and review it will be able to access it again. So I just wanted to give you a little bit of a heads up. Today's presentation is going to run for about 30 to 35 minutes with additional time at the end for questions. This is a bit of a PDCA to trial some of the techniques that were taught by James Hilliard as part of his webinar on proven steps to success when using WebEx. So there'll be a couple of spots for questions to be asked, but feel free to ask them at any point and put them on the chat, and we'll try our best to address them at the end of the presentation. And one of my colleagues here at HQC will be monitoring the chat. That won't be something that I'll be doing. So, a little bit of an introduction. This topic was selected through a vote that was taken on the Kaizen network call on what the next measurement topic to be covered should be. It beat out topics like what's on kaizentracker.ca and how to select continuous improvement measures. However, I think that learning how to cascade measures is a method that will actually enable you to select continuous improvement measures, so we're kind of covering that topic as well. So today's presentation is going to build upon the other measurement presentations that have been part of the learning series, or the QI Power Hour as it's now called. The first was a presentation on measurement and data that I gave last year. That was followed up by how to visually display data, given by Jessica Hamilton of HQC. The next was on driver diagrams, which was presented by Glenda Little from eHealth. And then finally, a presentation on run charts that was given by Adrian Danilou of HQC and Anna Liu of RQHR. So as a reminder, all of those presentations are available on SharePoint as well in case you missed them. And there is talk that they may eventually be posted to the HQC website so that they're more publicly available. So there's three main learning goals for today's lesson. The first is to understand the what, when, and why of cascading measures. The second is to describe the difference between cascading measures, and you can do that by structure or by process. And the third is to understand the importance of collaboration when you do this type of work. So I'm hoping that by the end of this you'll have a pretty good grasp of how to cascade measures, but I'm really not expecting you to walk away as an expert. That will come through trial and error, and it'll come through experience finding what works for you and for your organization. So there's a pretty decent chance that most of you on the line know who I am. I've probably met many of you, but if you haven't had the opportunity to meet me, my name is Doug. I work at the Health Quality Council, and I am now a Provincial Improvement Consultant, no longer a Kaizen Specialist. I still work in planning and reporting, but I've added a couple more pieces of paper to the wall since the last time I gave one of these presentations. I've completed my Lean Leader training as well as the Advanced Training Program in Healthcare Delivery from Intermountain Healthcare in Utah. So I'm going to try something a little bit different today, and we're going to get you to be a little more interactive than some of these previous WebExes. I'm going to give the permissions to annotate to everyone that's on the WebEx, and if you see on your screen in the upper left-hand corner, there's a bit of a dashboard, and you'll see an arrow there. And on this next screen, oh, sorry, I need to click over here. I'm going to get you to give the arrow a click, and then if you click on the arrow and then click on the screen, it will add your name to the screen, basically. So if you've attended all of the learning series, put your name up by the 12, and if you are attending your first one, put your name down at the other end. So it looks like a lot of you are new, which is kind of exciting. I'm glad we've got some new people on the call today. It looks like people are figuring this out, so I'll still give you a second to keep playing with it. Thank you for not drawing anything inappropriate. That is always appreciated. All right, so I think we've got it figured out. So I'm going to go over to the next screen, which is what is your experience level with cascading measures, and I need to figure out how to clear the screen.
The eraser.
Which is where?
Just below the yellow box, and then you can click on the arrow.
I gotcha. I don't know.
It should allow you to erase everything.
Well, we're still trying, so at least it was a decent idea. But I think if you click again, it will move your arrow to a new location, so you'll still be able to put your name where you'd like to. So One PDCA we'll call the fail forward fast, but it's kind of working, so thanks for playing along with me. Okay, so it looks like most people are fairly familiar with it, or at least they've heard of it, so I think that'll be a perfect audience for today's presentation. If there's any of you that are sort of up in that 3 level, feel free to chime in at any point and add your perspective as well, because I certainly don't know everything about this. Nice happy face. All right, I need to figure out how to clear that. There we go, magic. All right, so I've taken away your permissions to annotate, so now there'll be no more drawing on the screen. Okay, so let's get into the meat of the presentation and start with the what, the why, and the when of cascading measures. So for me, when I think of a cascade, I think of a waterfall down a set of stairs, essentially. The water's flowing from the top, and it flows down to each level in succession, and there's a bit of an order to it, it's predictable, and it's understandable. So cascading measures is pretty much intended to work in the exact same way. So what are cascading measures? Well, they're a set of measures that track progress towards a goal at each level of an organization. These measures flow down from the largest goal of the province, organization, or clinic, depending on your context, to goals that can be achieved at an individual level. So later in the presentation, I'll be breaking down 2 ways that this can be accomplished. But I do want to make it clear what cascading is not. It's not just using the same measure throughout the organization at all levels to track progress towards a large strategic goal. While this is possible to track that same measure from a provincial level down to the point of care in some instances, it's unlikely to think that that will drive the improvement necessary to change that big dot. So it's possible to measure almost everything, and that's why there are often too many measures to be effective. It can be time-consuming and costly to collect data, so that's why it's important to select the correct things to measure, and these things should be selected because they're related to your goals. And if you'd like more information on selecting measures, please refer to the presentation on data and measurement that can be found on SharePoint, and that covers outcome measures, process measures, and balancing measures. So why would you want to cascade measures? Well, as I mentioned, you want to collect the right data so that you can see if your improvement activities are accomplishing your goals. However, sometimes it can be pretty difficult to see how the work that you do might have an impact on a high-level strategic outcome. That's why a cascade of strategy and measurement becomes so important. So for example, here are some of the provincial goals for the Saskatchewan healthcare system. These are goals that everyone can have an impact on, no matter what they work on or where they work in healthcare, and for that matter, even outside of healthcare as well. These are very large goals, and it's pretty unlikely that everyone in an organization would be able to look at them and know exactly what they can do to achieve the target. So if I walked into a surgical unit and I said that, hey, your new goal is to reduce the ED weights by 60%, I think I'd probably get a few funny looks and I might even be asked to leave. But if I walked into the same unit and gave them a goal of increasing their screening rate for sepsis to 100%, I might be welcomed a little bit easier. Both of these goals will have an impact on the ED wait times. It's just that the screening goal is the part that that unit can play in reducing ED weights. And just as a side note, I would never want to walk into a unit and give them a goal. I would want to create that in partnership with them, but a little more on that later. So when would you want to cascade measures? Well, there's an official step in the Hoshin-Connery strategic planning process that's called catch-ball, and that's the step that's meant to align improvement efforts to strategic priorities while engaging the entire workforce in order to set goals and measure for the upcoming year. And this is actually fairly timely because right now the catch-ball process should be starting to occur in your organization, at least in an abbreviated fashion this year. So the catch-ball period that occurs in November and December probably isn't the only time that cascading measures could or even should occur. It's an activity that should probably occur year-round to examine your priorities and to ensure that you're capturing the right data to know if you're successful in the areas you intend to improve upon. So at this point, you're probably thinking, well, that's all really nice, but I actually don't think I've learned anything yet, and you're probably right. So let's get to some learning. I'm going to teach you now how to cascade measures. So, in my opinion, there's 2 methods that we can use to cascade measures. The first is called by structure, and the second is by process. The first method I'll walk you through is how to cascade by structure. This is likely the process that you're most familiar with. It looks like a hierarchy, and the goals and measures flow downwards through an organizational chart. So, at the highest level, whether that be the provincial level, the CEO and board level, or a different level, a strategic goal is usually set. The next level of the organization or clinic or whatever it happens to be, which is usually a service line, determines what they can do to impact the strategic goal of the organization, and they set a target to improve upon something. A department then determines how it can impact the service line goal, and they also set a target. A unit then looks at their department goal and determines what they can do to improve upon that and sets a target. And then you can even get down to the level where a staff member would say, what is my unit trying to improve and what will I personally be able to do to achieve that? So the visual on the screen follows the traditional structure of a cascade of strategy. This is a fairly simple concept, but you might be wondering how to choose a goal that impacts the level above you. That's where there's a very useful tool that can lay out those cause and effect relationships in a visual format. Driver diagrams. So most of you, I imagine, are pretty familiar with driver diagrams, but if you're not, here's the key. They make explicit the relationships between what you want to accomplish and what will have the greatest impact on how to get there. So there is a learning series presentation on driver diagrams and how to use them if you'd like to learn more, but I'll give you a very quick run-through of what they are. This is what a driver diagram looks like. There's the aim, the primary drivers, the secondary ideas, and the change ideas. The drivers are the key things that affect the level to the left. So for example, if your aim was to lose weight, the primary drivers would probably be calories in and calories out. Then the drivers for calories in would be determined, and so on. For each of these drivers, a measure would be selected. It doesn't have to be complicated. In the example I just mentioned, the measure for your aim would be your weight. The measure for calories in would be your caloric intake per day. Not rocket science, it's pretty simple. So how might you go about adding a measure to a goal? In the simplest of terms, I would recommend engaging your team to determine what you should measure to see if you're making progress towards your goal. Most of the time, it's going to be fairly obvious what you should measure, but not always, and it might take a little bit of work and some brainstorming. But as I mentioned earlier, there are presentations on this on SharePoint. So how does using that driver diagram become a measurement cascade? Well, if you take a look at the image on the screen, you can basically remove the drivers, and you've got your measurement cascade if you flip it 90 degrees. So there's your cascade. It's simple, it's pretty effective, and it shows what is being measured at each level of an organization in order to create alignment and achieve a strategic goal. Here's another example. Imagine your organizational goal is to reduce the number of preventable deaths in hospital. And, sorry, just as an aside, these are all made up. I'm not saying these are the correct answers to anything. They were just examples that I can show you to at least get the concept across. So if you're going to try and reduce the number of preventable deaths in hospital, you'd set some service line goals then. Maybe you're going to try and reduce sepsis or reduce the rates of HSMR. You would then set a department goal and say, okay, I'd like to reduce my transfers to the ICU with sepsis, and maybe there'd be some other drivers you could look into as well. Then you would break that down farther and set a unit goal of increasing the use of the sepsis bundle and ensuring all employees know the tools for sepsis screening. You would then set measures. So maybe the number of preventable deaths, fairly obvious. Then you would look at your sepsis rate. You'd look at your number of transfers for sepsis. And then you would look at the percentage of staff that are trained on sepsis screening and the percentage of patients that receive the bundle after a positive screening. That's how you would go about cascading by structure. Key to notice that we're not using the same measure at every level. They're all different measures, but they build towards that same goal. So here's the keys to cascading by structure. What's the main objective you're trying to achieve? How is this going to help achieve the goal of the level above you? How will you know if you've achieved it? That's really about attaching a measure to something. And what can your service line, department, unit, team, entire organization, entire clinic do to achieve the driver identified? And that's about selecting the improvement work that you will undertake. So does that sound like a familiar set of questions to anyone? I'm assuming it does to a few of you, and that's because those are the exact questions of the model for improvement, which is the fundamental model of doing quality improvement. And if you want to learn more about that, there's a pretty handy book called The Improvement Guide that I would highly recommend reading. So, unfortunately, there are a couple of issues with cascading by structure. There's the risk of developing silos of work through the cascade, as well as the risk that improvements made in one area may have a negative effect on another area. For example, if a clinic is able to see and process more patients in one day, that's great for the clinic. but it may have a negative impact on the pharmacy or imaging centers because they may not have the capacity to keep up with that new demand. So even if you improve something, it's tough to tell what effect that might have on other areas. I'm going to pause here for questions and thoughts at the moment. If anyone has feedback on how this has worked for them, I would be happy to facilitate a bit of that discussion, or if you've got questions about what I've said so far, feel free to shoot a question, or if there's anything on the chat as well.
Nothing on the chat yet.
Remember star six if you need to unmute your phone.
This is Carrie from Saskatoon. I think what you're saying is really great, and I just want to reiterate, I think the go and see model is really important, and the engaging of teams. What we've seen is that high-level goal is really great to create line of sight, but if we are not going and seeing and making sure that we understand what our business looks like and building a metric that way, it becomes not achievable, and it just becomes a top-down approach.
Thanks, Carrie. I totally agree with you, and that's part of the collaboration that's necessary to do this well.
We have a question from friend Sesko on the chat, and he's asking, what about the cost dimension? I don't know if he wants to unmute to maybe clarify his question.
Sure. I mean, I guess if he's got more thoughts, absolutely please unmute and elaborate. I guess you can definitely cascade cost up and down the organization as well. That's something that you would measure, probably the same thing at each level. What is the cost of your unit of service? But it's not something I've ever worked too much with, so if there's anyone on the line that has thoughts on it, I'd be happy to hear them.
I think with cost, you could look at dollar figures, or you could take exactly what was presented here and do the cost drivers, and that really relates to volumes and length of stay and harm events. That those are factors at the unit level that have a direct impact on cost. So I think depending on what end of it you're looking at, you could also do it the other way and just look purely at dollars in terms of overtime, sick time, and those kind of things. But the process that Doug has kind of laid out here would work exactly the same for cost. It's just really about understanding what drives cost.
Perfect. Thanks, Patrick. All right, I'll continue moving along. So,
actually, Doug, it's Carrie Lane. Can I just make a quick comment, too?
Absolutely.
I really appreciate you commenting on this being a part of Catchball, or this being a good time to do this work. It's a reminder that the questions around Catchball should not be, what do you think of this big measure, but how can you guys be a part of this? And I see a comment from on the chat about structure cascade is very top-down, and I think that the Catchball process is an opportunity to make sure, like Carrie said too, you go and see and you really talk to people about what does this look like for you and how can you be a part of it, not just, do you think this is a good goal?
Exactly.
Yeah, so the suggestion here on the chat, just for Doug, he doesn't have the chat right in front of him, so the suggestion of levitating measures, so something that comes from the frontline priorities and more patient-oriented, right, and goes upward to the organizational level.
Yep, absolutely. Questions? All right. Okay, so the second method for cascading measures is to cascade by process. So there is an order to how you would go about cascading by process, and these are the steps. However, I think it's going to be a little easier if I walk you through an example on what this looks like to cascade measures this way. But if you want to come back to these slides, here's your cheat sheet, essentially. So the first step is to identify a high-level process for your organization or for your clinic. You would then map that process using probably a value stream map, or you could just use a process map if you want to keep it a little more high-level, so that you can determine where the pressure points are that need to be improved in order to improve your overall process. Once you've determined what needs to be improved, you would set your strategic goal. Based upon your strategic goals, you could set goals for each of those process steps in order to achieve the strategic goal. Each process would then be broken down into sub-processes that make it up. Goals would be set for each of those processes, and this could continue on into multiple sub-processes of each step. Once the goals have been set, measures would then be developed for the processes that are being improved. If a process isn't being improved, don't create a bunch of measures for it. Measuring can be costly and time-consuming, so make sure you're using it if you're going to measure something. Instead, what I might suggest is consider finding a balancing measure for the process that shows if the improvements you're making somewhere else are having a negative effect on another step. So what does that look like in a real-life example? Well, let's say that we're working in a community clinic, and again, I don't work in a community clinic, so if anyone on the line says you're out to lunch, I probably am, but I'm just trying to give an example. So let's say we want to improve our processes, but we don't know exactly where we should start. The first thing would be to make a map of the high-level process for the clinic. So the patient enters, the patient checks in, the patient sees the doctor, and then the patient leaves. Pretty high level, but that's the general process. Then we would develop a strategic goal. So for this example, let's say we'd like to increase the value-added time that a doctor spends with the patient by 10%. Perhaps the first goal the team would set is that the doctor has all of the required information at the start of the visit so they can begin diagnosis immediately upon entering the room. But because the team is working together in a collaborative process, hopefully something like what Carrie was describing, they look at the process map and see that the actual leverage point to collect that information is when the patient checks in. So a goal would be set to ask patients all of the key questions at check-in. They could then break that process down into what questions get asked. So you might ask for the health card, you might ask demographics, and then you might ask some screening questions. And that would help them achieve their strategic goal. Perhaps they know that, oh, we're a little weak at asking screening questions. We don't do that all the time. So you would attach a measure to that. So now we've attached the key goals to our process maps, and we can now attach measures. So time spent at check-in, percent of patients the doctor needs to ask why they're visiting. So that's more of a defect rate. But there's your easy cascade of something that can be done at screening that will help the patient check in, which will increase the value-added time the doctor gets to spend with the patient. So that's how you would cascade by process. So there's quite a few benefits to cascading strategy and measures by process. The main reason, to me at least, is that the key leverage points in the process are visible, and this helps it become clear what you need to do to achieve your strategic goals. And you can see how each process impacts the others in the stream of care. So the cross-functional nature of the value streams will help to break down silos that can, unfortunately, exist in the workplace. But as with most things, there's a couple of issues with cascading by process. It can be difficult to build the value stream for large organizational processes, and it's not quite as simple and intuitive as it is to cascade by structure. But here's a couple key things to keep in mind when cascading by process, and these are more key questions. It's where are the bottlenecks in this process? So what is the data telling us? What do we know because we work in the process and we're the experts? And then what is that key leverage point that we can work on in order to improve our processes and achieve our goal? So I'm now going to give a bit of a real-life example that shows the two different methods for cascading measures, but for the same strategic goal. So to do that, I'm going to work through the example of ED weights. So for ED weights, as most of you are probably familiar with, but if you're not, it's to reduce the wait time in the emergency department by 35% by March 31st of 2018. So that's a pretty high-level goal. So how do we go about achieving that? Well, sort of if you've been listening, it's to break it down into manageable chunks. So here's how we would go about cascading that strategic goal by structure. At the top is our system-level goal. We would then determine what the drivers of that strategic goal are. So as a service line, the team would look at what they need to do to improve upon in order to achieve that goal. So let's say these are the possible drivers of 7-day revisit rate, 30-day readmissions, ALC patients in hospital, and avoidable admissions to the hospital. So a service line might pick 30-day readmissions. Our data tells us that's where we need to improve. So the key drivers of that might be something like discharge planning, communication of information, and patient self-management. So let's say, again, they pull the team together and they decide that the place we really need to improve upon is the communication of information flow. A key driver of that might be doing medication reconciliation. So from that, you've got your key drivers that you can attach measures to your goals at each level. So you could do the ED length of stay might be your high-level goal or high-level measure. Number of 30-day readmissions might be your service line measure. Number of patients with a completed history might be a unit-level measure. Percentage of MedRec complete could be a measure below that. So if you take away your structure there's your measurement cascade. And you could actually do that down to an individual level of percentage of MedRec completed by person X if you wanted to get that granular. So one of the things I really like about this example is that MedRec probably isn't the first thing that I would think of doing that would improve ED wait times, but once you work through the drivers, you can see that there is a line of sight from improving that to improving your strategic target. Here's how you would go about cascading that same strategic target, but by process instead of structure. So first, let's imagine we developed a high-level value stream map for our care process. So a patient might become sick, they might visit the ED, then they would get admitted to acute, then they would head back to the community, and then hopefully they would get well. So it's a very high-level process, but I think it works for this example. So the next thing you would do is look for bottlenecks in this process to see where you can improve. And here's a bottleneck that might be found, the ED wait time. So you would want to set a strategic target around that. You would then set goals regarding those high-level processes. Having a team that understands the process where the bottleneck is occurring, you would then create a value stream for where that bottleneck is. You would look for a key leverage point in that process based upon data and the opinion of the team to determine what you should work on improving. Once you've selected what you need to improve, you could dig further into that process until you get to a level where specific actions can be taken. So now that you're at an actionable level, you would attach measures to your key processes and work to improve them. So what's most interesting about this method to me is the interaction between the processes and the ability to see how a change in one area might affect others. So for this example, if patients get from the ED to acute quicker and are then discharged to the community faster, the services in the community would need to be able to keep up with the demand. Otherwise, the bottleneck would just move downstream to the community. So there is your measurement cascade. We end up with basically the same measures, it's just a different method of getting there. So as for what type to use and when to use it, for me there isn't really a correct answer. Cascading by structure helps with individual or group accountability towards a goal, and it does develop a good line of sight to a strategic outcome. But cascading by process helps with shared ownership of issues and becomes cross-functional. Cascading also shows that interaction between the processes and how a change in one area might affect the other. So the process model focuses more on the patient journey within the service, which is something I like as well. So cascading measures and collaboration. So just a couple of quick points to add at the end, but I think they are some of the most important. The main thing is you can't do this by yourself. The people doing the work at each level are the experts. They understand the processes and they understand the drivers, and they should be used to create the solutions. So admittedly, as I said, I created these cascades with the help of a couple people at HQC, but we're not out on the floor every day, so my apologies if these processes weren't totally correct. But that's why we need to engage others to help do this work properly. Engaging others gives space for team building and can go a long way in helping to break down silos. Learning the process you're involved in affects how it affects the rest of a clinic or an organization or the province is an opportunity that really probably shouldn't be squandered, because I think it's quite valuable. So in wrap-up, here are a couple of key points I'd like you to walk away with today. That cascading strategy leads to cascading measures, and there's two good ways to do that, and probably even more. But one is by structure and one is by process. And then make sure that you engage others in those processes. So as one last sort of final aside, I've given several presentations on lots of different topics, different audiences, but one of the more common questions that I get asked is, how does this relate to our lean journey? Is this a departure from our lean journey? What does this mean? So before I get asked that question, I decided to make it explicit how cascading measures fits with those tools and concepts that we've been learning. Value stream mapping is basically the core of how you would cascade by process. Driver diagrams are the core of how you would cascade by structure. Continuous improvement and PDCA are the methods that you would use to improve to do quality improvement and achieve strategy. Daily visual management is the method that you would use to track your progress towards the goals you've set and how to look at those measures that you have selected. And then Hoshin-Conry, or strategic planning, is the formal time when cascades can be developed. So that is it for the presentation, right at a half hour on the nose, so hopefully it was short enough to keep your attention and keep you engaged. But now we'll open the floor back up for thoughts and questions. there anything on the chat, Jocelyn?
I did pose the question that R. Edwards had. I sort of read it as a comment, and then I look back and see that it's more of a question, right? So the idea that Dean is supposed to empower folks on the front line. What about levitating measures, as I mentioned earlier? So I think he's just curious to know, you know, how that might fit in, or maybe how that works. And I did pose it out to folks if you want to speak up on the call. You know, what experiences might you have had with that type of strategy, sort of working from point of care up?
This is Alex D. Pietro. I'm the Director of Communications for Kuwait and Yate Health Region. Good morning, everyone. Just my question is in regards to the last point, so from the takeaways and how this fits into our lean journey. Can you just go over again, please clarify how it fits with the Haudenosaunee, please, because I didn't understand that.
Sure, absolutely. So the Haudenosaunee process is essentially about how you select goals and select work in order to achieve a strategy. So there is a step in there called catchball, which after a high-level strategy has been developed during plan development by the provincial leadership team, which is the senior leaders of the province, the CEOs and the board chairs, there's a provincial plan that goes out. And the thought behind catchball, if it was executed perfectly, is that plan gets basically talked about at the CEO level, and then they would take it to their senior leadership table where they would discuss it and say, I either agree with these goals or I don't, and here's what I can do to achieve these goals. So they would set goals. Then those senior leaders would take it down to whatever, the director level or the manager level, and then that discussion would occur there of, as an organization, this is what we think we can do. What can you do in your unit or your department that would help these goals, and then does it make sense as well? So are the goals that the senior leadership team is setting, are they achievable? Do they make sense for what you think the actual issues are? So it should cascade up and down the organization that way of, here's what we think at the level above, what's your opinion and what can you do to achieve these goals? And then please give your feedback if these goals are not correct so that we can modify them, which links into the question about levitating measures of, I would say normally the cascade seems to flow from the top down, but it should have that opportunity to go from the bottom up as well. So once it gets to the point of care, they should be putting in their input on, are the goals that were set above us achievable? Here's what I actually think we should be working on because this is the key issue, and that it can cascade back up the organization that way. And hopefully, in theory, that those high-level goals may be modified based on what was levitated up from the bottom.
I also think a lot of our goals are levitating in a sense of we're from the patient perspective, right? So we're trying to improve things from the patient, who is ultimately the foundation of our care. So then we're trying, if you look at the patient and you listen to the patient, it does cascade up as well as cascade down. I think all goals cascade up and cascade down if you're truly a patient-centered system.
And maybe just to add to that, I think the idea of levitating goals or from the bottom up is actually built into the Haudenosaunee process, and it really starts with diagnosis and review. And I mean, again, it's kind of one of those things where, you know, if you have those, if you understand your processes at the unit level and have measures attached to that, it's during that diagnosis and review phase that you feed up the information to say, you know, we're doing good on MedRec, but we're struggling with our sepsis bundle, just to kind of piggyback on. So, and Mallory's point also through the engagement. So I think it is built into the idea of from the bottom up to set strategy is built into the Haudenosaunee process, but it is very much dependent on how robust the measures are at the unit level.
All right, thank you very much. Very good answer. Thank you.
Thanks.
Hi, this is Ajinkya here from Saskatoon. I essentially have a comment. The comment is about when cascading does take place, there are many people who feel that there are some measures which do not flow up to their VPs or their directors, and that's why they are hesitant to kind of keep track of them. So I think it's also important to recognize that there are some essential parts of their business which might not flow up, which might not levitate up, but it's very important to still keep track of them, and we have to ensure that they feel comfortable in like visually keeping track of them and making it visual at their level. Thanks.
Thanks,
Ajinka. Any other thoughts or questions on the line?
Yeah, I've got a few things coming in here.
Sure.
So I've got a comment saying our current fiscal reality means we need to find improvement opportunities that will deliver better care at lower costs and focus on the big drivers of healthcare costs. Absolutely. And a consideration that cascading by process could be a challenge because they do not often end up in service provision. We sometimes need to assume that our processes lead to improvement.
Yes.
I think one of the challenges with cascading by process, in a lot of ways, right, if you had great information, that would be the way to go, but it's very much dependent on strong value stream maps and good understanding of all the processes and sub-processes.
And that little skinny line that's red.
R6 mutes your phone.
That's a triple 20, so that would be worth 60 points.
Yeah, just a reminder to star 6 so we can hear someone's conversation. Probably a good conversation. But...
Yeah, Mom?
All right, well, Jocelyn, do you want to open up the poll? So, again, just thank you very much for attending today. I definitely appreciate it. We had a fairly large audience, which is awesome. So hopefully you did learn a little bit about cascading measures and how you can use them to amaze your friends at parties. That's probably not going to happen, but you never know. Might be some different kind of parties out there. So the poll will be opened in your WebEx window to fill out and give feedback on today's presentation. So it would be appreciated if you could take a minute and fill that out. And if you've got thoughts on what a future type topic for this should be, then we would actually love that feedback as well, because I think we need to set up what our spring QI Power Hour will look like. So again, thank you very much, and we'll talk to you in the new year.
Thanks, Doug. Bye.
Thank you.